we will start with cardiac function evaluation. These are parasternal long axis views of the heart. The right ventricle is seen at the top of the image. This is the interventricular septum, and this chamber is the left ventricle. This valve is the mitral valve, and this chamber is the left atrium. The M mode or the motion mode is applied. The M mode is helpful in examining cardiac function. Ejection fraction is the percentage of blood that is pumped out of the left ventricle during systole. The normal ejection fraction is considered to be between 50 to 65%. In echocardiography, there are various ways to calculate the ejection fraction. The first method is to measure the mitral valve E-point septal separation on M mode. Place the M mode cursor on the tip of the mitral valve during early diastole when the mitral valve is open. The M mode gives us a one-dimensional view of the cardiac structures over time. The anterior structures or the upper part of the image is seen at the top. So the skin is seen at the top. Then we will see the right ventricle. This is the septum, and below the septum is the left ventricle. These waves are the mitral valve leaflets. Mainly, we will see two waves throughout the cardiac cycle on M mode. The first wave is the E point. The E point is the upward deflection of the mitral valve leaflet during diastole. The second wave is the A point, which is the deflection of leaflets during atrial contraction. The distance between the E point and the septum is the E point septal separation or EPSS. We have to measure this distance. The normal EPSS is less than 7 millimeters. This means that the ejection fraction is within normal range and cardiac function is normal. This image on the right is of abnormal EPSS. The EPSS is 17 millimeters, so this is abnormal. And EPSS greater than 7 millimeters is usually suggestive of ejection fraction less than 30%. Keep in mind that EPSS value directly does not give us ejection fraction. It is only an indicator of reduced left ventricular function. Fractional shortening is the percentage of reduction of left ventricular internal diameter during systole. The normal range is between 25 to 45%. It is calculated automatically by the machine after we measure and input the internal diameters of the left ventricle during end systole and end diastole. In these images, the end systole diameter of left ventricle is 3 centimeters, and in end diastole the diameter is 4.4 centimeters. These can be measured on M mode. Place the M mode cursor just below the mitral valve tips. You can measure the widest and narrowest regions in the M mode representation of the left ventricle in this manner. So these values are used by the machine to automatically calculate fractional shortening. This is the formula used. N diastole left ventricle internal diameter minus N systole internal diameter divided by N diastole internal diameter into 100. This gives us fractional shortening. In this image, we see a very low value of fractional shortening. The left ventricle seems to be dilated and thus gives out a fractional shortening value of only 7%. This means that the heart is not contracting effectively during systole and indicates heart failure. These are normal and abnormal ejection fraction values. They are measured using modified Simpson's method, in which the endocardial border is traced in apical 4-chamber and 2-chamber views. This is used to calculate left ventricle volume at end diastole and end systole. The left ventricle length in this image is 12.2 centimeters and the area is 54 centimeters square. The end diastole volume is 194 milliliters. The image on the right is of an abnormal ejection fraction. You can see a dilated left ventricle. The end diastolic left ventricle volume is 233 milliliters. These images are of the same case. These measurements are taken at systole. These are the values we got in the normal image. The end systolic volume is 79 milliliters. This resulted in an ejection fraction of 60%, which is normal. In the image on the right, the volume is 217 milliliters. The ejection fraction here is 40%, which indicates reduced left ventricular function. Mitral annular plain systolic excursion, or MAPS, is the term given to displacement of mitral valve during systole and is used to evaluate left ventricle function. Mitral valve annulus is the ring-shaped structure that surrounds the mitral valve. It is located between the atrium and the ventricle. At this point, MAPS is calculated using M mode. Pass the M mode cursor through the annulus like this during systole. We will get this type of wave in M mode. We have to measure the size of the wave in this manner. This measurement is the MAPS. In normal cases, this measurement is more than 10 millimeters and indicates a preserved ejection fraction. Over here, we have an abnormal MAPS value. The M mode cursor is passing through the mitral annulus and it gives a very flattened wave. So by measuring the size of this wave, the MAPS value is only 6 millimeters, which is abnormal. A value less than 8 millimeters usually indicates an ejection fraction less than 50%. that is an impaired EF. If the value is below 7 millimeters, it usually indicates EF less than 30%. It is a severely impaired ejection fraction. Fractional area change can also help us in measuring systolic function of left ventricle. It is calculated by measuring the difference in the end diastolic and end systolic areas of the left ventricle and expressing it as a percentage of the end diastolic area. It is automatically calculated by the machine once we input end diastolic and end systolic areas of the left ventricle in systole and diastole. Fractional area change is expressed in percentage and is normally between 35 to 65%. Now we move on to right ventricle function. Tricuspid annular plane systolic excursion or TAPS is a measure of the longitudinal motion of tricuspid annulus in the right ventricle during systole. TAPS is measured by placing an M-mode cursor through the tricuspid annulus in the apical four-chamber view, and the distance that the annulus moves during systole is measured in millimeters, similar to MAPS. The cursor passes through the tricuspid annulus, which is located here, and gives us this M-mode tracing. This wave is measured. In normal cases, this value is more than 17 millimeters. In this image, the TAPS value is less than 17 millimeters. These are the TAPS values which correspond to an approximate ejection fraction percentage. This is the fractional area change for the right ventricle. Right ventricle area is measured in apical four-chamber view. The normal fractional area change is between 33 to 60% approximately. Systolic excursion velocity is a measure of the velocity of the tricuspid annulus during systole, typically obtained using spectral Doppler. We can call it S prime. It reflects the longitudinal contraction of the right ventricle and can be used as a parameter of right ventricular systolic function. S prime is usually measured at the lateral tricuspid annulus, and a reduced S prime may indicate right ventricular dysfunction. Doppler gate is placed at the lateral wall of right ventricle slightly above tricuspid annulus, and we will get this waveform. This is the systolic excursion velocity. Normally, it is more than 10 centimeters per second. This case is of an abnormal systolic excursion velocity. We see a reduced velocity. It is less than 10 centimeters per second. This is a normal heart in apical four-chamber view. We can see all four chambers, valves, and the septum clearly. Here we measure the right atrium. Two measurements are taken. The longitudinal axis is the major axis. This measurement is usually less than 5.2 centimeters approximately. The horizontal axis is the minor axis. It is usually less than 4.5 centimeters approximately. The vertical axis is the superior axis. It is usually less than 5.2 centimeters approximately. The horizontal axis is the major axis. It is usually less than 4.5 centimeters approximately. The vertical axis is the minor axis. It is usually less than These two measurements give an approximate area of less than 18 centimeters squared. And in this image, we see right atrium enlargement. We see a dilated right atrium. The left atrium is measured by tracing the endocardial border, and we get an approximate volume of 35 milliliters per meter square in this image. And over here we have left atrial enlargement. We can see a dilated left atrium. Now we will discuss heart valves. Starting with mitral valve. Here is the mitral valve in apical 4-chamber view with color Doppler applied. The flow is smooth. No color mixing or turbulence is seen. Mitral regurgitation is a heart condition in which blood flows backward through the mitral valve from the left ventricle to the left atrium during systole. In a mild case of mitral regurgitation, a small jet of turbulent flow is seen in left atrium during systole. The central jet width occupies less than 20% of the left atrium. Vena contracta is the narrowest part of the turbulent jet. In mild cases, it measures less than 3 millimeters. The regurgitant volume is less than 30 milliliters per beat, and the regurgitant fraction is less than 30%. In moderate regurgitation, the central jet occupies between 20 to 40% of the left atrium. Also, mild flow convergence is seen near the mitral valve, which is the narrowing of regurgitant jet as it flows through the orifice of the mitral valve. In severe regurgitation, the central jet width occupies more than 40% of the left atrium during systole. The entire atrium is filled with turbulent regurgitant jet. A large flow convergence is observed near the mitral valve. The vena contracta measures greater than 7 millimeters. The regurgitant volume is greater than or equal to 60 ml per beat, and the regurgitant fraction is more than or equal to 50%. Mitral stenosis is a condition in which the mitral valve opening is narrowed, restricting blood flow from the left atrium to the left ventricle of the heart. A turbulent flow is seen in the left ventricle during diastole. So, in stenosis, the turbulent jet is seen in the ventricle during diastole, whereas in regurgitation, the turbulent jet is seen in the atrium during systole. In mild cases of stenosis, the mitral valve area is greater than 1.5 centimeters square. The mean gradient is less than 5 millimeters of mercury. These parameters are calculated by tracing the outline of the mitral valve orifice using two-dimensional imaging to measure the area. In moderate stenosis, we see a larger turbulent jet in the left ventricle. The valve area is between 1 to 1.5 centimeters square, and the mean gradient is between 5 to 10 millimeters of mercury. In severe stenosis, the valve area is very narrow. It is less than 1 centimeter square, and the mean gradient is greater than 10 millimeters of mercury. This is a spectral waveform of a normal mitral valve. Mainly it gives two prominent waves. The first wave is the E wave or the early diastolic filling wave, and the second wave is the A wave or the atrial contraction wave. The peak velocity of E wave is between 0.6 to 1.3 meters per second or 60 centimeters to 130 centimeters per second, and the A wave velocity is between 0.6 to 0.9 meters per second or 60 to 90 centimeters per second. The EA ratio is the ratio of velocities of E and A wave. The normal ratio is between 0.8 to 1.5 approximately. The normal deceleration time is between 160 to 240 milliseconds. It is the time it takes for the peak velocity to come down to zero. And over here we have a spectral waveform of severe mitral stenosis. We will find spectral broadening and very high velocity flow. The velocities are reaching almost 200 centimeters per second. In this case, continuous wave Doppler is used because it is able to detect very high velocity flows. This is an image of severe mitral regurgitation. There is a high velocity flow reversal with spectral broadening. The velocities are reaching 4 meters per second or 400 centimeters per second. So that is a very high velocity. This is an image of a normal aortic valve with color Doppler applied, and these are the normal values. The aortic valve velocity is between 2.5 to 3.5 meters per second, and the pressure gradient is usually around 10 and 20 millimeters of mercury. In aortic stenosis, the aortic valve is narrowed and does not open properly. This leads to turbulent flow in the aortic root. Also, we will find non-mobility or reduced mobility of the valves. These are images of aortic valve without color Doppler. We can see the aortic valve right here. It is open. The cusps are thin and will move normally throughout the cardiac cycle. This is a case of aortic stenosis. The valves are hyperechoic and are less mobile than usual. Here is a spectral Doppler waveform of a normal aortic valve. This is how the waveform will look like. The peak velocity is usually less than 200 centimeters per second. And over here we have a case of mild aortic stenosis. We can see spectral broadening because of turbulent flow. And the peak velocity is between 2.5 to 2.9 meters per second. The mean gradient is less than 20 millimeters of mercury, and the aortic valve area is greater than 1.5 centimeters square. The area is usually between 1.5 and less than 2 centimeters square. In moderate aortic stenosis, the aortic jet velocity can be between 3 to 4 meters per second or 300 to 400 centimeters per second. You can see the aortic jet velocity here is more than 300 centimeters per second. Also, there is spectral broadening. The mean gradient is between 20 to 40 millimeters of mercury, and the aortic valve area is between 1 to 1.5 centimeters square. In severe aortic stenosis, the jet velocity will be more than 4 meters per second. Here you can see the velocity is above 4 meters per second. The mean gradient will be more than 40 millimeters of mercury, and the aortic valve area will be less than 1 centimeters square. These are cross-sectional images of the aortic valve during systole and diastole. And over here we have mild aortic valve calcification. You can see a small hyperechoic region on the aortic valve. This is due to calcification. This image shows moderate aortic valve calcifications. You can see a greater extent of hyperechoic areas on the aortic valve. This image shows severe aortic valve calcifications. The entire valve is filled with hyperechoic calcifications. In aortic regurgitation, the aortic valve does not close properly. This causes blood to flow back into the left ventricle from the aorta during diastole. In mild aortic regurgitation, the central jet width occupies less than 25% of left ventricular outflow tract. That means only a small area of the left ventricle is filled with a turbulent jet. Turbulent flow is seen during diastole, starting from the aorta and reaching the left ventricle. The vena contracta measurement is less than 3 millimeters. This is a spectral Doppler waveform of mild aortic regurgitation. There is spectral broadening and a high velocity flow. The velocity is almost 4 meters per second. Here is an image of moderate aortic regurgitation. The turbulent jet is larger than in the mild case. It is going from the aorta to the left ventricle during diastole. In severe regurgitation, the central jet width occupies more than 65% of the left ventricular outflow tract. The vena contracta will measure greater than 6 millimeters. Here is a spectral Doppler waveform of severe aortic regurgitation. There is flow reversal during diastole and a high velocity flow is seen. The velocities are more than 5 meters per second. So that is a very high velocity. Now we move on to pulmonary valves. This is an image of a normal pulmonary valve. This image shows the right ventricular outflow tract. The normal valves are visible during diastole and are invisible during systole. In pulmonary regurgitation, a turbulent flow jet can be seen going from the pulmonary artery to the right ventricle during diastole. This is a normal spectral Doppler waveform of pulmonary valve. The PSV is usually less than 150 centimeters per second. The acceleration time is less than 120 milliseconds, and the ejection time is between 180 to 200 milliseconds. And over here is a spectral waveform of pulmonary regurgitation. We can see diastolic flow reversal over here, and there is high diastolic velocity as well as high systolic velocity. Here is an image of pulmonary stenosis. The turbulent flow jet can be seen going from the right ventricle to the pulmonary artery during systole. Now we will see spectral Doppler analysis of pulmonary stenosis. In mild cases, the peak velocity is less than 3 meters per second. There is some spectral broadening, and the velocity here is approximately 3 meters per second. The peak gradient is less than 35 millimeters of mercury, and the right ventricular systolic pressure is between 31 to 49 millimeters of mercury. In moderate pulmonary stenosis, the PSV is between 3 to 4 meters per second. The peak gradient is between 36 to 64 millimeters of mercury, and the right ventricular systolic pressure is between 50 to 79 millimeters of mercury. In severe pulmonary stenosis, we see a very high peak systolic velocity. It is greater than 4 meters per second. The peak gradient will be more than 64 millimeters of mercury, and the right ventricular systolic pressure will be greater than 80 millimeters of mercury. Now we will move on to tricuspid valves. In this apical 4-chamber view, with the color Doppler applied in the right ventricle and atrium, we can see normal blood flow through the tricuspid valve. There is no turbulence or color mixing over here. And over here we have a case of mild tricuspid regurgitation. A turbulent regurgitant jet is seen in right ventricle. The central jet area is usually less than 5 centimeters square. In severe tricuspid regurgitation, we see a large turbulent jet in the right ventricle. The central jet area is more than 10 centimeters square. This is a normal spectral Doppler waveform of tricuspid valve. The peak velocity is usually less than 2 meters per second, and the pressure gradient is usually less than 25 millimeters of mercury. And over here we have severe tricuspid regurgitation. We can see a very large jet velocity exceeding 300 centimeters per second. The vena contracta measurement is more than 7 millimeters in severe cases. Here is a case of tricuspid stenosis. The valves are thick and hyperechoic. Thick hyperechoic valves are often the cause of stenosis. The mean pressure gradient is more than 5 millimeters of mercury. The trans-tricuspid velocity time integral is more than 60 centimeters, and the valve area is usually less than 1 centimeter square. Here is a case of tricuspid stenosis with its spectral Doppler waveform. The peak velocity can exceed 2 meters per second, and there are other features such as spectral broadening. The normal pericardium appears hyperechoic like this. Pericardial effusion is the accumulation of fluid, blood, or pus in the pericardial cavity. Here is a mild pericardial effusion. There is anechoic fluid, a small amount of fluid in the pericardial cavity. Here is a case of moderate pericardial effusion. There is a larger amount of fluid in the pericardial cavity. In this image, we can see a very large amount of pericardial fluid. This can lead to a condition known as cardiac tamponade. Here is a parasternal short axis view of the left ventricle, and we can see some fluid in the pericardial cavity. Cardiac tamponade is a condition in which the large pericardial effusion starts to affect the cardiac cycle. The heart function is compromised. We see a very large effusion surrounding the heart. Usually the right side of the heart is affected. The right ventricle is collapsed and there is improper or absent diastolic filling of the right atrium and right ventricle. Pericarditis is the inflammation of the pericardium. Usually it is associated with pericardial effusion, but we can also find thickened pericardium in some cases. Ventricular interdependence is a term used to describe the changes when a change in pressure of one ventricle affects the functioning of the other ventricle. In conditions such as pulmonary hypertension, we may find interventricular septal flattening. We see a flat interventricular septum as compared to the rounded configuration in normal cases. We also find a D-shaped left ventricle. Also, there will be reduced left ventricular filling. We also find pericardial effusion in this image. A sigmoid-shaped septum is an anatomical variant in some individuals. There is some thickening of the septum over here. It can cause mild obstruction of left ventricular outflow tract. Cardiomyopathy refers to heart muscle disease. Restrictive cardiomyopathy is a rare type. In this type, the right atrium and the left atrium are dilated. This is a spectral Doppler analysis of restrictive cardiomyopathy. We will find a small A wave. The deceleration time will be less than 160 milliseconds and the EA ratio will be more than 2. There is diastolic dysfunction. In hypertrophic cardiomyopathy, there will be asymmetric septal hypertrophy. We can see a thickened septum. The septal thickness will be more than 15 millimeters. Due to the thickened septum, a condition known as systolic anterior motion of the mitral valve occurs, in which the anterior mitral valve leaflet moves towards the interventricular septum during systole. This causes obstruction in the left ventricular outflow tract. This is usually associated with hypertrophic cardiomyopathy. We will also find abnormal EA ratio and diastolic dysfunction. In apical aneurysm, there is localized dilation of the left ventricular apex. We can see a dilation of the region. This is usually associated with hypertrophic cardiomyopathy. Non-compaction cardiomyopathy is rare. A spongy appearance of myocardium is seen in this type of cardiomyopathy. This is how the myocardium will look like. In dilated cardiomyopathy, we will find dilated ventricle. Most commonly, the left ventricle is dilated. The normal internal diameter of the left ventricle in end diastole is between 4 to 5.6 centimeters. In dilated cardiomyopathy, this diameter can exceed 6 centimeters. Here is an image of a normal pulmonary artery. The normal diameter is less than 25 millimeters. And over here we have an image of pulmonary hypertension. We find a dilated pulmonary artery. The diameter will be more than 25 millimeters. Here is a spectral Doppler waveform of pulmonary hypertension. The velocity at the tricuspid valve will be very high. It is more than 4 meters per second in this graph. It is associated with tricuspid regurgitation. Transposition of the great arteries is a congenital heart anomaly in which the aorta and pulmonary artery are switched. The aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. In echocardiography, the aorta and pulmonary artery are seen parallel to each other in a parasternal long axis view. In a short axis view, we can also see the parallel configuration of aorta and pulmonary artery. The aorta is seen anterior to the pulmonary artery. Truncus arteriosus is another congenital heart defect in which only a single artery arises from the heart. We only find one artery over here which drains both the left and right ventricles. Also, it is associated with a ventricular septal defect. Patent ductus arteriosus is a condition in which the ductus arteriosus, which is a fetal blood vessel, fails to close after birth. The connection remains between the pulmonary artery and the aorta. Here in the normal image, we see a normal aortic arch and normal ascending and descending aorta. But in this image, we see a small connection between the pulmonary artery and the aorta. This connection is more clearly seen with color Doppler in a suprasternal view. This right here is the connection between the pulmonary artery and the aorta. Tetralogy of Fallot is a congenital heart anomaly consisting of 4 features. It consists of ventricular septal defect, an overriding aorta in which the aorta is centered right above the ventricular septum, between both the ventricles. Also, there will be right ventricular hypertrophy, and the fourth feature will be right ventricular outflow obstruction. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.